So without further ado, we'll introduce Dr. Feldman-Winter, and she's going to be talking about safe implementation of skin-to-skin care.
Thanks, Rebecca. Can you hear me? Just checking.
Yep.
Okay, great. So welcome everyone to the Wednesday webinar, and thank you for logging on at this unusual time at 12 noon Central, 1 o'clock out here Eastern time. I was hoping for a thaw of all the snow, but in fact it's snowing as I speak again. So welcome to the Northeast. I'm very appreciative that you're all on the call today, and I hope, because I don't have too many slides, that this will be an interactive conversation about really breaking down step by step the implementation of Step 4 of the Baby Friendly Hospital Initiative and really understanding how best to support skin-to-skin care. And as I often theme my talks, this one, as you can see, has a red background because when things don't go well in the delivery room and there's an unexpected, unfortunate outcome, it does have everyone seeing red. So my hope is that when things go wrong or poorly, that everyone will not only have a response that is appropriate to what happened, but really before anything goes badly after a delivery, that everyone will actually have a plan in place to anticipate that sometimes things don't go as planned. And so without further ado, I'm going to present my disclosure slide. I do not have any further disclosures. And as I already provided the overview, my hope for today is that you will understand the importance of skin-to-skin care, identify some of the safety concerns that have been raised about Step 4 of the Baby Friendly Hospital Initiative, and to use quality improvement principles to help develop a stepwise approach to improve the safety of Step 4 and identify common pitfalls and the appropriate responses. And so before I go on, I'm going to present a case. This is a modification of a real case. Baby M is a full-term newborn delivered to a 38-year-old Gravida1 Para 1 product of infertility treatment and IVF. Tea-colored thick meconium was noted in the late stages of labor, and the NICU team was called to the delivery room. A second-year OBGYN resident assisted mom with a normal spontaneous vaginal delivery of baby M, and upon delivery, the resident received the baby and with the cord attached, immediately placed the baby skin-to-skin with his mother. L&D nursing staff noted the poor tone, lack of spontaneous respirations, and called out to the resident to clamp and cut the cord so the baby could be moved to the warmer bed for neonatology to provide resuscitation, including positive pressure ventilation. Baby M was intubated within minutes and taken to the NICU for further care. Nursing staff in the room were overheard complaining about the resident delaying cord clamping and placing the baby skin-to-skin. Similar complaints were overheard by the NICU staff. So, what went wrong? Was this really a result of the resident error? How does the finger pointing help? What does the resident even know about CPR and neonatal life support? Are OBGYN residents even NRP certified? So I want you to consider these questions as I continue with the webinar this afternoon. So first, I want you to consider that there are indeed risks of mother-baby separation during this golden hour, when the baby ordinarily ought to be skin-to-skin continuously, uninterrupted. The skin-to-skin golden hour is really the standard for newborn care. It will avert breastfeeding problems. It will avert temperature instability, physiologic instability, and if mothers and babies are separated, there's interference with early newborn maternal bonding. And so it is part of step 4 of the Baby Friendly Hospital Initiative, not only to help mothers to initiate breastfeeding within 1 hour of birth, but really to create the environment in which this is most likely to occur. And so the focus of attention, which was always on breastfeeding within the first hour as part of the BFHI, has really shifted to providing skin-to-skin care uninterrupted for an hour after birth if babies are not going to be breastfeeding, and until the first feed is completed if babies are breastfeeding. And normally that occurs around an hour, but may occur after the first hour. It may occur before the first hour is completed, but just because that feeding is completed, it doesn't mean that the baby needs to be removed or separated from the mother. And there's really advantages, physiologic advantages, to keeping that mother and baby continuously skin to skin for at least 1 hour, if not even longer. And as stated on this slide, this applies really to all types of deliveries, vaginal or surgical deliveries. And more hospitals are moving to being able to provide mothers with opportunities for skin-to-skin care after surgical deliveries. So what does it look like, a safe and healthy transition in the normal newborn? So typically the heart rate's stable and not elevated or depressed after babies are delivered during the transition from birth to skin-to-skin care. The baby's circulation has to make dramatic changes from the in utero circulation through the placenta to now, after the cord is severed, to having the lungs expand, become oxygenated, and that be the mechanism by which blood that is oxygenated now flows through the heart and to the rest of the body. And there's plenty of evidence that skin-to-skin care really ought to be the normative type of care that occurs after delivery. There's evidence that it helps the babies, as I mentioned, stabilize their body temperature, and in preventing hypothermia, it actually also prevents hypoglycemia. It also provides that cardiorespiratory stability, particularly in the late preterm baby. And it will also provide babies pain relief. It helps to improve their autonomic and neurobehavioral maturation, helps babies actually sleep better by establishing better neurodevelopment and brainwave patterns, and also helps those babies establish better breastfeeding behavior. For mothers, there's advantages as well, and there have been studies both in newborns as well as their mothers that providing that skin-to-skin care will actually decrease stress as measured by catecholamine levels. There's also evidence that skin-to-skin care will do a lot of good to helping mothers establish breastfeeding. So it permits the babies to have a more organized suckling pattern, which gives moms more confidence, and it makes it more likely that mothers will achieve their breastfeeding goals. So what does a normal delivery actually look like? So for many of you who spend a lot of time in the delivery room, you know what it's like to be in the DR. And I would say it is almost impossible to spend time in the delivery room without everyone's catecholamines rising. It's a very stressful environment. There's a lot of anticipation, excitement, but there's also a tremendous amount of worry. Worry because we always are hoping and expecting for a healthy, well baby, but worrying about the baby that is delivered that is not so healthy. So how often does that happen? Well, it's good to know that 85% of the time, babies are born healthy and initiate spontaneous respirations within 10 to 30 seconds of birth. 10% will respond after that light stimulation. 3% will initiate respirations following positive pressure ventilation, so requirement for actual resuscitation. 2% will need to be intubated, and only 0.1% will actually require chest compressions and real cardiopulmonary resuscitation. So what this slide, I think, illustrates is that healthy is the norm, which is great, but there's a tremendous amount of worry that occurs because of the unhealthy. So given that, what are the exceptions to immediate and continuous skin-to-skin care? And these are points that were elucidated in the recent clinical report that was published by the AAP. So any newborn requiring positive pressure resuscitation, it is important to not only postpone skin-to-skin care in order to administer that, but then if the baby then returns to the mother for skin-to-skin care, that baby be continuously monitored. Babies that have low APGAR scores, so the heart rate less than 100 at a minute, or less than the APGAR score less than 7 at 5 minutes, any medical complications that would compromise the respiratory effort or provide cardiac compromise, meconium-stained amniotic fluid, as was mentioned in the case that I described, and I'll return to that, but definitely in a baby who is meconium-stained, in that baby, if there are absent or depressed respirations, or the heart rate is less than 100 beats per minute, or there's poor muscle tone, then that baby would be resuscitated on the warmer bed. So that would be an exception to immediate skin-to-skin care. So it's important that everyone go through those 3 attributes, again, tones, respiratory effort, and heart rate, less than 100. Any one of those 3 features would mean that that meconium-stained baby should receive resuscitation on the warmer bed. And then finally, a maternal indication if the mom is unstable because of hemorrhage, or she requires resuscitation, or is not alert and awake and able to respond to her baby. And all of that is really presented in this algorithm that is part of our neonatal resuscitation program. And I want you to focus primarily on the upper third of this slide. So you have a baby who is term and delivered, breathing, crying, good tone. Yes, then that baby goes immediately skin to skin with the mother, with the cord attached, and care is continued to be supported on the mother, and the mother becomes the environment for care. If, however, the baby is not spontaneously breathing or crying, doesn't have good tone, the first step is to provide light stimulation. And that light stimulation includes clearing the airway, drying the baby, stimulating the baby. And if then the heart rate comes up above 100, the baby is then breathing and the baby has good tone, then that baby can be transitioned to the mom's perineum initially, and then brought up to the mom's chest, initially with the cord attached still, and providing that physiologic cord clamping. So that's just light stimulation. It's really in the absence of a response to that light stimulation that then that cord would be severed and the baby would be taken over to the warmer bed for additional stimulation. So what are some of the unnecessary, and I quoted them, exceptions to skin-to-skin care that we often hear when we go around to hospitals and are looking for reasons why babies and mothers didn't get an opportunity for skin-to-skin care? The newborn sort of non-indications include infants of diabetic mothers, which include some of the babies that would be on the hypoglycemia protocol. A suspicion of chorioamnionitis. There are some facilities that, for some reason, have a very high rate of what they deem as chorioamnionitis, but I think there's just a low threshold for calling it that in the absence of febrile mother, babies otherwise well. Prematurity, and this is a real question. I think most people would agree, even with the NRP guidelines that I just showed you, that the late preterm babies, 35 weeks and older, can be cared for similar to a term baby as long as they follow the indications for immediate skin care. Maternal indications that are non-indications include a mom who's febrile. There's no real contraindication for that baby to have skin-to-skin care, even if the mom's febrile. And I think that in many facilities where you have many mothers that will not remain in the caregiving position, they will not remain with their newborns following delivery, the babies are being given up for adoption, et cetera. It really depends on the mother's wishes, and moms ought to be given that choice. Also consider other support persons who might provide skin care. If the mother can't, then there is often someone else who could be in the delivery room who could provide skin care, again, providing all those great benefits to the baby. So what are the risks? And these are real questionable risks. We don't know and have no evidence that providing skin-to-skin care is at all related to or correlated to this concern that has been often raised, which is sudden unexpected postnatal collapse, or SUPC. We don't know if these events are coincidental or somehow confounded by skin-to-skin care. It may just be that there is a period of non-observation and they would occur in the old newborn nursery should things return to the old ways of bringing the baby immediately to a separate room like the newborn nursery. The risks may be airway obstruction, depending on how that baby's positioned, falling, delays in care, and many hospitals are worried about the fact that immediate skin-to-skin care precludes the ability to get a baby's weight. Really, waiting for the weight is not a problem. So you can, in fact, wait for the weight. And most experienced newborn care providers can eyeball a baby who may be SGA or LGA and be able to say, yeah, that baby looks like they'll probably end up on a hypoglycemia protocol, but you really need to do anything in terms of testing a blood sugar until that initial hour and a half is already up. So babies can still get that initial skin-to-skin care, which will actually make their numbers better in terms of preventing hypoglycemia. Again, delays in care occur when there's a delay in responding to a change in status. So that occurs when babies are in skin-to-skin care but not monitored. So moms and babies shouldn't be left alone unmonitored in the delivery room because that delay in care can actually be a risk in and of itself. And I'll return to that in a little bit. And then hypoglycemia, but as we just heard, really it's skin-to-skin care that prevents hypoglycemia. So when we think about shifting, and it's a huge shift to go from the old way of every baby being born, taken to a warmer bed, taken then immediately to a newborn nursery, to now being immediately placed skin to skin, cord attached, moms being the environment to care. When we think about that shift, so many things need to happen. The first thing that an institution should do really is take that 10,000-foot view. We really have to all be in alignment that this indeed has become the new philosophy of practice. And to do that, you need administration buy-in. Administration has to be able to support the team to actually engage in the changes that are going to need to occur to do this. And And part of that is determining what the best methods of communication are and then fitting that into what your institution's usual methods of communication are. If communication is an issue in your institution, then you have to develop some new mechanism of communication. If you have things like unit council or department meetings or residency education sessions or portals where you have required learning activities, then those processes are already in place. Use those mechanisms for communication and then disseminate the education. There's evidence behind everything that we're saying, but some people just need to read all the primary literature in order to really get buy-in. So that's okay. You know, I think there's no end to the amount of information that should be circulated. It's not that there's any secret. Every institution has to have mechanisms to provide all the necessary education and materials for everyone. And last but not least, involve your marketing team. If you do this for a few moms, you're going to realize they're going to have stories to tell that are very positive and will be very helpful. Share those stories, interview those moms, tell your stories of success, and publish them in your newsletters, because that will make everyone feel good about all the things that have to change and occur in order for step 4 to be put in place safely. So the next thing you want to ask is, what happens when there's a Sentinel event in your institution? What is your usual institutional response? Who's responsible? What do you have in place? Do you have the Mortality and Morbidity Review Committee? Do you use root cause analyses or FMEAs or clinical case conferences? What's your mechanism? And make sure that all the people that are a part of that mechanism, whatever it is aware and understands that this is a change and that the details of what's necessary to put in place to actually convert your normal setting to provide continuous skin-to-skin care and breastfeeding support in that first hour. So why would SUPC or sudden unexpected postnatal collapse be considered a sentinel event? Is it? And so let's define what a sentinel event is. A sentinel event is an event defined by the Joint Commission, which is an accrediting agency for 90% of the hospitals in the United States. So it's an event defined by them as any unanticipated event in a healthcare setting resulting in a death or a serious physical or psychological injury to a patient or patients that's not related to the natural course of the patient's illness. And so it's not clear by that definition if SUPC is something that occurs naturally. It certainly is unanticipated. But really, when you dig down into sentinel events, one of the things that really is a red flag for whether it is a sentinel event or not is that there is a delay in treatment or response. And so this is why continuous monitoring is so very vital for at least the period of skin-to-skin care, but I would say for the first 2 hours for every delivery. Every organization that is Joint Commission accredited is strongly encouraged, but not required, to report sentinel events. And the reason to report is that the Joint Commission is not just there in a punitive way. They're not there to give certificates when you do well and sort of, provide sticks when you're not doing well. But they're really there with a variety of resources to help every organization improve quality and safety. And they have a variety of tools and mechanisms to help institutions do that. So there's a benefit by reporting sentinel events when they do occur. It's really keeping these sorts of things secret is not healthy for the institution. So this is just a pictorial view of what a root cause analysis may look like, and this was an unfortunate maternal death and a published root cause analysis. And the whole concept here is that when sentinel events occur, they don't occur because of a person or a procedure or a lack of a lab test or one thing. they're often the result of system errors, and systems involve lots of different things. And they involve people. So there's people that are staff and healthcare providers, but other people also that work in the institution. There's people because there's patients, and so patients have their individual characteristics that may make a sentinel event more likely. There's also work environment. There's organizational issues. There's team factors. There may be environmental issues. You know, there may be just too much distance between one location of providing care to another location. It may be that the NICU team is located too far away from the delivery rooms. They can't get there in time. Every institution has their own prongs, if you will, for these root cause analyses. And really, this is the best way to approach a sentinel event. Other folks, particularly those in pharmaceutical industry, use the Swiss cheese model when they think about patient safety issues. The concept here is that when you align all the holes in each one of the parts of the system in such a way that the event slips through all these holes that are in alignment, that's when harm occurs. And so this is just another way to visualize the root cause analysis by thinking about all the different components of the system. As I mentioned, the team is important, the organization, the culture of the organization, even funding and resources, there's technical support, and then again, there's people like providers. So I like this joke because it is so true. To address this mistake, we need to utilize our thorough system of root cause analysis. I will begin, if I may, by pointing out that it's not my fault. This is so common. So it's not just the Joint Commission, but the government, Department of Defense, and the Agency for Healthcare Research and Quality have come together to create an entire process or program for institutions to help improve patient safety, to help improve institutional quality. And these are some of the key principles, as I've already mentioned. Just that team structure. What does your team look like? And how are they empowered to do the work of getting skin-to-skin to occur in a safe and consistent manner in the delivery room? How do you guys communicate, or how do you not communicate is probably the better question. Do you cascade different elements of communication throughout the prongs of leadership in your institution, or did things come from the grassroots up? You know, what's the mechanism for how things are, how information is transferred? What does your leadership know and do in terms of supporting this activity? Situation monitoring, which I'll come to in the next slide, and then finding ways to support each other, because change is hard, and people do get frustrated, particularly when there's a bad event. So the situation monitoring is best done by this acronym SBAR. And again, this is part of the team steps approach. The situation itself, what happened, what's the background, so understanding the institution and the patients, assessing what could have happened better in terms of everyone on the team using best judgment, using the evidence, and then recommendations for going forward. And after you have your institutional approach to patient safety sort of hammered down, you know what's going to happen should, hopefully not, but should a sentinel event occur. The next step in really putting this in place is simulation. You want to practice exactly what's going to happen using SimMom, SimNewbie, and really going through step-by-step what it's going to look like in the delivery room. You don't have to order all the fancy dolls that you see in this image, but really going through the simulated delivery using the NAUS protocol that I presented. And then once you've done that in simulation, you're going to test. And you're going to test with one baby, one mother, one OBGYN or family medicine physician, one pediatrician or neonatologist, one OB nurse or L&D nurse, mother-infant unit nurse, resident, student, whoever you want to put on that initial team. You're going to test it with one team, one group at one time. And you're going to plan for it, and you're going to make sure you have all your necessary equipment. You're going to put in place everything that you thought about during your simulation, and you're going to carry it out. You're going to do skin-to-skin for an hour. Or 2 hours, and assist and support with breastfeeding. And when you do that, someone's going to be there recording. So you need to remember to have a recorder. They're the fly on the walls. They're going to take notes, and that's the study. They're going to capture everything that goes right and everything that doesn't go right, and then you're going to debrief and think about how to make this better the next time. And as you continue to make it better and better, then you ramp up skin-to-skin with more staff, more days of the week, more shifts during the day, even on the weekends. And you can see here that the quality improvement project focused on skin-to-skin contact after surgical deliveries was actually published in Jargon because, again, these plans are replicable and can be utilized throughout multiple institutions in order to get this in place. So step by step, 1 through 5 first. And again, these are all delineated in the clinical report by the AP. The first step, obviously, is the baby's delivered and the baby's dried. And if stable, the baby's placed immediately skin-to-skin with the mother, cord attached. And the baby's continued to be dried. The blankets are replaced by dry blankets. The wet blankets are taken away. And the baby's continually assessed during that period of time. So you have that minute cord attached. And I'm really harping on this issue of cord attached. As you know, ACOG came out with a bulletin supporting the concept of, some people call it delayed cord clamping. I prefer to call it physiologic or preferred timing of cord clamping, or appropriately timed cord clamping. And this is just a schematic of the physiology of why this is so important. The placenta continues to perform gas exchange even after delivery. And following umbilical cord clamping, the right ventricle filling volume actually drops abruptly, such that the flow of blood that comes from the umbilical vessels into the right ventricle drops by about 50%, so that the right ventricular output decreases by 50%. In addition, in the worst case scenario, if the baby doesn't breathe immediately after birth, then you have continued increased pulmonary vascular resistance, leading to even less flow back into the left atrium. And there's not enough blood flow in the right ventricle to push blood through the open foramen ovale, and you have deoxygenated blood with a decreased cardiac output, leading to hypovolemia and hypoxemia to the brain, and there's an increased likelihood of interventricular hemorrhage. And this is why, particularly in the premature newborn that's susceptible to interventricular hemorrhage, why babies are recommended to have their cord clamping delayed, and even babies that need resuscitation, there's question of whether milking the cord would actually even help, but really delaying that cord clamping has become the standard of care. And we think this is important even for full-term babies because, in fact, that little bit of cerebral hypovolemia, hypoxemia, maybe that's part of what's underlying these SUBC events. Never been proven. We don't know if that's the case, but certainly one theory that would be supported by the physiology. So step by step continued, 6 through 11. So you continue to dry the baby, except for the hands. So everyone asked when we wrote this clinical report, well, why not the hands? And as many of you know, it's important that the baby be able to lick and taste the hand and smell the hand, because that is the smell and taste of amniotic fluid, which allows that baby to then connect amniotic fluid with the smell and taste of mom's colostrum, and it actually aids in recognizing mom's breast and at early breastfeed. There's debate about whether it's necessary to cover the head with a cap. Just drying the head and the rest of the body is probably sufficient. Again, using pre-warm blankets to cover the body of the baby but not the head, leaving the face exposed in a neutral position, and then assigning that 5-minute APGAR score. It goes quickly, as most of you know, but all of this can be done in addition to assisting and supporting with breastfeeding. These are just some tips in terms of safe positioning during skin-to-skin care, and the whole purpose of this list is to avoid the obstruction of the baby's airway that would cause any problems with continued breathing during skin-to-skin. And again, it's important to ensure that the mother is alert and awake, able to respond to her baby, that the mom doesn't become distracted in any way, and that the baby is monitored in case the mother is distracted for whatever reason or her situation changes. And so, in conclusion, of course, change is hard and definitely messy in the middle, gorgeous at the end. But I want to return to the case of baby M, and I want you to think for a minute, you know, what went wrong? Was this really the result of resident error? Was this baby going to end up being intubated and resuscitated anyway? And the NICU course, you know, would it have been any different if that baby hadn't gone immediately skin to skin after delivery? And we know the baby had meconium. We know the baby didn't fulfill all their criteria to remain there following that first minute. But ultimately, the baby did go to the warmer and receive resuscitation. So I think so. This is really points for discussion and the questions I have for the group, and it would be great to know again how everyone is set up, how your hospitals are set up to handle these events should they occur. So I'm going to stop here and see from Rebecca if there's any questions, or if anyone wants to raise their hand, we can definitely unmute you.
I don't see any questions in the chat, but if anyone has a question, they can unmute by hitting #6 on their phone, or they can also send a message in the chat as well. You can either send it privately or to everyone. If anyone has any questions.
Hello, everyone. This is Anne. Laurie, that was a great webinar. I had something I just wanted to maybe ask you about. I know you've talked about sudden infant collapse in other webinars, and it's not exactly the same, but I do think sometimes we have issues where at least in terms of the baby, you know, what everybody thinks when the baby's born, it looks like the baby's born perfectly healthy, and then baby's pursed skin to skin, and then suddenly it's noticed, and of course that's a very dubious concept, like when is it noticed? Would it have been spotted before? Should it have? But it's noticed that the baby is suddenly gone blue, as people put it, or got, you know, is really not breathing, and I wonder if you could speak a little bit to that, which is not quite the same as when a baby's born and everyone's already seeing some flags, like in your case, but the baby has, you know, suddenly something happens and people say, oh, that was because it was skin to skin.
Yeah, so thanks for that question, because that definitely has come up. So it's important for everyone to note that babies are born blue, and that is part of the normal physiologic circulation that occurs in utero. Babies are born cyanotic. They're supposed to be blue. And the process of the baby becoming pink occurs over time. really over 5, sometimes 10 minutes, which is why very often an APGAR score of 9 is great. Why isn't the baby at 10? What do you get that 1-point demarcation for? It's for color, because it is normal that it takes time for baby's color to transition, because it takes time for the lungs to open and for that blood that's then circulating through the lungs to get oxygenated, and for the blood not to bypass the lungs and so really go in through the right ventricle into the lungs and not bypass by going through the foramen ovale into right over to the left heart. So that said, a baby that may look vigorous initially, they're not going to be pink, but may look vigorous and have good tone initially, that then all of a sudden loses tone or the heart rate goes down and seems to, quote, stop breathing, is most likely a baby that really had a cord clamp too soon. And so, again, that cord clamping abruptly diminishes by 50% how much blood flow is going to get out of the heart, and it's all going to be deoxygenated. And just that will, in fact, lead to the sequence of events that might interfere with that baby continuing to breathe and the heart rate continuing to be stabilized and normal. And so it's important to keep the cord attached, to keep monitoring that baby, to allow for the baby to breathe. And I think people forget to watch the baby breathe. And that can happen during light stimulation. They just don't have to scream and cry. They can have a little cry, but as long as they're opening up their lungs, which can happen slowly and patiently, but they have to open their lungs first before the cord is clamped in order for this sequence of events of having cerebral hypovolemia, cerebral hypoxemia not to happen. Babies have to breathe first, and then the cord may be clamped and severed in order for that sequence of events not to occur. So I think what's happening often in the delivery room, again, there's so much adrenaline, everybody's so rushed to do everything. It's kind of like me going through a slide presentation. I'm really rushed to get to the end, you know what's coming next and you just can't wait to get there. It's so hard to kind of step back and allow that baby's color to slowly change over time and allow the baby to breathe before that cord is then clamped and severed. And I think when babies are placed skin to skin, what's interesting, when they've tested babies' heart rate before and after placing skin to skin, babies that are not skin to skin actually have an elevated heart rate. But that's probably not physiologic, but it is probably the fact that the skin to skin causes physiologic lower heart rate, but then in combination with the clamp cord, that causes that baby to kind of spiral downward. So the sequence of events is so very important for that baby to have a safe and normal transition. And it's interesting because hospitals are just getting with the program on this, and probably many unnecessary resuscitations have occurred because we just never got the sequence of events quite right beforehand.
Laurie, I know
going on forever.
You said about the baby going pink. If it's a baby that's not got white skin, like a black baby, is skin tone like what? I mean, many of us may or may not know that, but I'm just curious, like, what would the skin tone color expect to be at the beginning? Can you see the change in a baby that's born, that's a black baby, an African-American baby?
You can. I mean, it's really all mucosal skin that you're looking at, but yeah, if you're not looking at the lips, then it may be difficult in a more darkly pigmented baby. It may be more often missed in a darkly pigmented baby, a black baby, than in a Caucasian baby. So it may be that nobody really knew that the baby wasn't making that transition from blue to pink. But that transition takes some time. It's just important not to clamp the cord too soon during that time, and that you watch for respirations and tone. If you have a hypotonic baby, then that's a baby that needs stimulation or maybe even resuscitation.
Thank you.
Anyone else? So it's interesting because in discussing this case further, in terms of my questions about what does the resident know about CPR, are they even NRP certified, and who drives that process? As it turns out in this hospital, I got feedback immediately, well, the resident shouldn't be responsible because it's the nursing staff that drives that process. If that baby, didn't fulfill these 3 criteria, the nursing staff in the DR would be the one to drive the process to bring that baby over to the warmer bed for resuscitation, which I found quite interesting, that it was the person holding the baby was the resident. The OB attending is in the room, but the person driving the bus is really the OB, LND nursing staff, which is fine if that's really the case. It's just funny to me, or seems questionable to me, that in fact everyone wouldn't actually be on the same page, that those processes in the same thought process wouldn't be in sync. And so to me, it doesn't matter who's driving the process. Really, everyone should be driving the process and driving it together. There should be some synchronous way to drive that process. But in the end, what ended up happening was all this finger pointing, and I think there's a lot of finger pointing when you take ownership. And I think of it like an adolescent. So if you have an adolescent parent who is 100% on top of their teen to study and do their homework and get good grades, and they get good grades, well, in the end, who's celebrating? It's the parents. The kid doesn't even feel like they did it because their parents were so instrumental in everything that happened that led to the teen getting good grades. So at some point, I think the nursing staff has to step back a little bit and share ownership, so that everyone is kind of part of the ownership of what's happening in the delivery room. Everyone needs to be on the same page, and everyone needs to be communicating in ways that are effective and not really finger pointing. So if something bad happens, it's really shared ownership as well. But if things happen that are good, then everybody gets to share that ownership as well. Any other questions or comments? You can disagree with me, of course.
Lori, do you hear me?
Yes.
It's Dottie Shell.
Yes.
Hi, it's Dottie Shell from Pennsylvania. First, thank you for emphasizing the delayed cord clamping, because to be really honest, I knew it was valuable. I don't think I fully grasped how important it really is. So talk about change. Thank you.
Yeah.
The other thing that we've noted is that the delivery rooms usually have the neonatal resuscitation program reference charts in them. And,
in the room. Mm-hmm.
Right, and if the staff just read that, it says birth, is the baby term, is he has good tone, is he breathing or crying? And if he is, then he goes to mom, but he's always supposed to be observed. And I think somewhere in there, people are missing that boat, that the baby's not being observed for the continuing muscle tone, et cetera. And sometimes staff is over charting or whatever, and not that you have to be staring at the baby the whole time, but you have to be aware of the baby at all times. And so if they just the protocol that they're already following should work for this. But I think people are thinking it would be a separate protocol. But the position, everything, it should be for all babies.
Yeah, and I mean, because it doesn't specifically spell it out in NRP, I think it does get lost. So that's why I think it's important for all of us to integrate the skin-to-skin piece in to NRP, because it really is part of the standard of care. It's unfortunate that, it's just not there spelled out in black and white, but I agree with you. you know, it's all right there, and then the continuous monitoring has to occur because that's when there's the highest risk of events occurring. So,
yeah, one of our hospitals had an event, and the nurse said the light bulb moment was when somebody pointed out to the NRP. She said, "Oh my God, it was there all, we were just treating as these things as two separate things, and they're not."
Exactly. Exactly. Yeah, sometimes it does come back to just going back to the basics and just everybody being on the same page with the basics. That's the other thing. It's like it's not just one person's responsibility. I think everybody needs to kind of revisit the protocol and understand why and why it's spelled out that way.
So,
you know,
can I ask you something? Sorry.
Yeah.
No, I just want to ask you something related to the thing I keep harping on, because that is definitely the most distressing thing when a hospital calls us up and says, well, you know what, the baby like nearly died and we have to leave it. In your experience, because you have broad experience of this, is there almost always a reason for that? Or like when they do the root cause analyses, do people come up with a reason like, okay, we realize why that happened, next time it won't happen? Or is there is a percentage of these things that, you know, it would have happened anyway, possibly. There was nothing we could do to prevent it. It just happened to be that the baby was in skin to skin instead of the warmer. I'm just curious, like, what percentage of these things end up with some explicable reason that either it was human error or it was a defect in the baby's heart or something, and what percentage of them, I mean, maybe we don't know, but I'm just curious what your experience is. You know, what's that? How does that
I think we don't know, but I think what we do know is that more often than not, there's a delay in the response to the event. It's like, oh my God, when did this baby stop breathing? Oh my gosh, when did this baby's color all of a sudden go from pink to blue? So it's the delay, it's the, oh, when did this happen kind of thing. The delay, the absence of knowing when the baby changed to the period of time that the resuscitation then occurs, that people are most uncomfortable with, and that's what really drives it to become a sentinel event, because there's this delay in a response. And we don't know because of the fact that most of these occur with that delay. It's not that the event happens and immediately there's a response. If you hear these stories, there's always this period of non-observation. You know, there's this period of time where the details are fuzzy, right? I mean, you've heard some of the stories. I've heard a lot of the stories. There's this fuzzy period. Well, that fuzzy period really begets this concept that this was a period of time when there was no observation. So if there was continuous observation, it may be that the baby could have become in a bad position, and that there was some assistance and support to put the baby back into a more neutral position, or that the mother, you know, changed because she noted that the baby had stopped breathing, like periodic breathing or whatever, but that there was some response that then averted a problem from happening.
Yeah, there's that horrible sort of phrase. That horrible sort of phrase, you know, the baby was found to be unresponsive.
Was found
to be. That's exactly. That's what we hear, exactly. And it's like, well, what do you mean exactly was found? Like, when was it found? Where was it before? Yeah.
That's why that one slide that I put in here really points to this idea that it's the delay in response that really points these events to being a sentinel event, that really drives the engine that the institution needs to do something about this, because there was a period of non-response. There was obviously a period where the baby wasn't observed, or mother wasn't observed. So how many can be averted? I think we just don't know, you know. I think it'll be a good question if truly we practice the way we're saying, which is for continuous observation. How many events occur even under direct observation? Well, that will be telling. You know, I do think that there may be some, just like with SIDS, that have whatever channelopathies or some other defects, genetic issues that lead to these events. We still believe that this is a separate entity from SIDS, but, you know, I think that the jury's out even on that because we don't know. It's a diagnosis of occlusion. So I'm just going to read someone's message here. Just wanted to agree totally. Everyone in the delivery room should be in sync and trained in NRP to respond if needed. Good, I'm glad they agree. So I'm not coming out of left field. I think it's everyone. I think the residents and OB and nursing staff and kids people, everyone. Any other questions or thoughts? It's a tough topic. You know, it's something that no one wants to happen, but I think we need to talk about it. So appreciate your attendance and thoughts.
Okay, if no one has any other questions, thanks, Dr. Feldman-Winter, for presenting, and thanks for everyone for attending. The recording of this webinar and the slides will be on our website. And if you have any questions for Lori, you can always email us at champsbreastfeed@gmail.com. Our next webinar will be April 26th, and the topic will be race and breastfeeding. So we hope you guys can join for that one. Thanks, everyone. Have a nice day.
Thanks, Rebecca. Have a great afternoon.